This first question I will direct to Dr. Reckman and Dr. Antonoff. Are there situations where local ablation is actually going to be superior to using your forms of local therapy in the cases of metastatic cancer?
Yeah, so I'll go ahead and respond to this. But I'm interested in what Dr. Antonoff has to say as well. For ablation, it's generally considered in candidates who aren't available for other types or of local therapy, such as radiation or even surgery. So it's really a last line option. A lot of the data doesn't report local control. It's more progression-free survival. For a local control modality, I think it's pretty important to specifically report local control. I don't want to call out specific devices, but in one recent study with just 6 months of follow-up for a certain type of local ablation, a third of them got SBRT to the same spot later on. The local control with SBRT is 95%. 1 to 2% of people have short or long-term toxicities from it. But I do have a few patients in clinic who are highly motivated to avoid systemic therapy despite excessive counseling. And they happen to have a slow pace of disease. So over many years, I might spot weld, a few areas in the lung. But I get to a certain point where I'm like, oh gosh, I don't feel comfortable to treat more. I literally have just, a few patients where this applies to. And I have a rock star interventional pulmonologist, and we're talking about getting this specific technology, for that reason. But I'm a little worried it might collect dust on the shelf because, I don't want to have any patient-facing advertisement for these because folks are going to think it's the best thing since sliced bread, and radiophobia is a very real thing. And I want people to be offered the treatment that has the strongest safety and efficacy. In reality, these devices are often cleared by the FDA for, quote, ablation of soft tissue, quote, and not for treatment of cancer. So I think it's really important, if these things are being advertised to the public, that is not refusing other systemic or other modalities such as surgery or radiation. That is seeing an advertisement and going to that person that offers that. All folks being considered for ablation should visit with a radiation oncologist. I'm just going to say that frankly, and that is definitely congruent
Yeah.
with
And a surgeon.
guidelines. Yeah. So, but anyway, that's kind of my 2 cents. I think you guys can see my bias. The
Yeah.
more data there is for safety and efficacy, I think it's the more important to offer those treatments as first line. I don't care what patients choose. I just want for them to make an informed decision.
Right. I totally agree. And so I'll give you a little pushback, Dr. Singhi, on your question, because you asked about certain circumstances where it's going to offer superiority. Superiority of what, right? Like there, so, Dr. Reitman has pointed out efficacy. So maybe I don't think there's any circumstance where the superiority of efficacy. I simply don't. There are definitely situations where it's the only option, it's the best option, it's the remaining option. But it's just it's never going to be a superior efficacy. There may be times where it's acceptable efficacy and not in stage 4 disease. I think it's going to be acceptable efficacy for really small, perhaps, pre-malignant lesions or very small, metastases from other sites of disease. But ultimately, we have pretty expansive data showing that for once you get beyond a certain size of a tumor, surgery is a little bit more effective than radiation in terms of recurrence risk for certain sizes of tumor, certain, once you're beyond a certain number of centimeters. And that's specifically SBRT. We have other modalities of radiation that are going to work in other circumstances. But ablation doesn't even come close. And I think we've got ample data to show that. And I think where it becomes challenging is that there are individuals who care for many different cancer types, not only different cellular cancer types, but in different body parts of the body that are going to respond differently to things like ablative therapies. And so we run into challenges where, for example, someone does a great job of taking care of colorectal cancer that has spread to the liver, which responds really well to ablation in the liver. But Right. the lung is a completely different organ and it has different blood supply, it has different tissue density, and all of those elements are going to impact the way something like ablation is going to work. And so you asked other patients for whom it's superior. I don't think that I can think of a circumstance like that, but there are patients who, for example, have been treated with max doses of radiation, Right. cannot get reirradiated to that spot. It's not safe to operate for whatever reason. Those are situations where We don't throw in the towel. We continue to look for other strategies. We add the armamentarium, and there are ways to provide ablative therapies through a transthoracic approach, meaning like through the outside of the chest, directed by an interventional radiologist, or bronchoscopically down through a scope that goes into the airway through the windpipe that can address it from either direction. But I think, like Dr. Reichman said, any patient who's being offered an ablative therapy should have the opportunity to talk to all care practitioners that may offer a different type of local therapy because it just doesn't come close to surgery and radiation in terms
Yep.
of efficacy.